Presentation title: Implementing Urinary Incontinence Management in Primary Care. Case Studies from AHRQ's EvidenceNOW initiative. Thursday, November 14, 2024, 2:30 p.m. to 4 p.m. Eastern Time and 11:30 a.m. to 1 p.m. Pacific Time. This presentation contains complex visual elements that are not described by the narrator. To provide audio description without ruining the flow of this presentation, long passages of description have been provided at the end of the presentation to provide full access to all content. AHRQ. Agency for Healthcare Research and Quality, Department of Health and Human Services, USA. EvidenceNOW, Managing Urinary Incontinence, an AHRQ initiative. Speaker: Elizabeth Cope.
So hello, everybody, and thanks so much for joining us today. We are pleased to have this opportunity to talk with all of you about the latest work emerging from AHRQ's Managing Urinary Incontinence initiative, which is one of the programs in their EvidenceNOW portfolio. All of the EvidenceNOW programs focus on using the model of delivering external support to primary care practices to assist in the implementation of evidence in practice settings. So we're here to learn about how this is working specifically in the context of urinary incontinence, a condition that has significant clinical and quality of life implications for many women, and which is compounded by issues like stigma among patients and burnout among clinicians. And we're delighted to have folks representing AHRQ, two practice change initiatives, as well as some frontline practice staff here to share their experiences. And we are also excited that all of you have decided to join us to learn more about this. Before we dive in, I do just want to share a few quick words about today. So if we can move to the next slide.
Agenda: 1. Opening. 2. AHRQ Welcome. 3. Grantee Implementation Case Studies. 4. Moderated Q&A. 5. Resources and Tools. 6. Closing.
Thank you. All right, so we're here today to inform, excite, and inspire, hopefully. Over the next 90 minutes, we're going to hear from AHRQ's Director of the Division of Practice Improvement about the current state of the Managing Urinary Incontinence program and how it fits into AHRQ's broader portfolio of initiatives. Then we're going to join two grantee teams as they describe their journeys to implement practice changes in primary care to achieve better care and outcomes for women with urinary incontinence. And we're lucky that we'll get to hear from multiple voices from each team to help bring to life a more complete picture of what this kind of work actually looks like on the ground. And we'll be closing out by sharing about some resources that the MUI project teams have developed and that are now available on AHRQ's website to help all of you in the work that you all do. But of course, no discussion would be complete without hearing from all of you. So please know that we will have time to address your questions. To help with facilitation, we're keeping lines muted for the duration of this session. So we ask you to please submit your questions through the Q&A box, which, if you'll notice, is actually separate from the chat window. So we'll be monitoring the Q&A box throughout, and we'll have time to raise some quick clarifying questions to our speakers after each presentation, and then time for more robust discussion at the end of both. Once both presentations have concluded, we'll have that broader discussion. Of course, throughout, please feel free to use the chat to engage with each other as well as the content. And in fact, you should feel free to start doing that right now if you want to throw in your name, affiliation, and where you're from so we can all kind of get to know who's on the call. I think that would be great. And then now, before I turn over, I'm going to do just a couple of housekeeping points. This meeting is being recorded, and meeting materials will be uploaded to AHRQ's Managing Urinary Incontinence webpage following this meeting. So if you want to access those or tell your friends to access them, that would be great. Also, at the end of the webinar, we'll prompt you to complete a survey in your browser, and a link to the survey will also be sent in a follow-up email from Zoom. These are really important to us and our team, so please fill it out and help us improve our events going forward. All right. This is what you're here for. So let's get to it. To kick things off for us, it is now my pleasure to introduce Dr. Xinji Zhang, who serves as Director of AHRQ's Division of Practice Improvement in the Center for Evidence and Practice Improvement. Dr. Zhang.
Thanks, Elizabeth. Good afternoon or good morning, depending on your time zone. First, I would like to welcome you to this wonderful webinar organized by Academic Health. We hope you enjoy the case studies from AHRQ's EvidenceNOW initiative. Next slide, please. AHRQ was originally established as an agency on December 19th, 1989. This year, we are celebrating our 35th anniversary. Our mission is to improve healthcare for all by producing evidence to make healthcare of higher quality so that it is safer, patient-centered, timely, effective, accessible, efficiently provided, and equitably distributed. As many of you know, AHRQ's Evidence-Based Practice Center program has developed more than 800 reports summarizing evidence on medications, devices, and other healthcare services. AHRQ's Making Healthcare Safer reports have helped healthcare providers, health systems administrators, researchers, and others understand evidence-based practice to improve safety across patient care settings. AHRQ also offers Medical Expenditure Panel Survey, MAPS, Healthcare Cost and Utilization Project, AHRQ, and the National Healthcare Quality and Disparity Reports. Next slide, please. So equitable person-centered healthcare delivery is at the heart of AHRQ's health service research. The EvidenceNOW model, which is originally developed to improve heart health in primary care patients through practice facilitation and coaching, has since expanded to enhance care for women with urinary incontinence, improving screening and treatment for unhealthy alcohol use, and build state capacity to advance equity in heart health. The EvidenceNOW Cooperative developed tailored support packages for primary care practice they work with, combining 5 core services that are typically unavailable to smaller practices, including practice facilitation coaching, health information technology support, shared learning collaboratives, expert consultation, and data feedback and benchmarking. Next slide, please. The MUI work presented today is a great example of how to close the gap between evidence generation and the implementation through a sustainable and equitable approach. According to a recent systematic review, fewer than 30% of women over the age of 40 with urinary incontinence report receiving any care for their symptoms, despite the availability of safe and effective non-surgical treatments. Therefore, in February 2022, AHRQ launched this initiative to help primary care practice implement patient-centered outcome research on effective non-surgical interventions for UI, including behavioral approach, medications, neuromodulators. We thank our grantees and colleagues from these institutions for leading this great effort. Next slide, please. At this stage, MUI grantees have successfully achieved the initiative's goal. As you can see here, screening more than 47,000 women so far from diverse racial ethnic backgrounds, as well as varying demographic and socioeconomic groups. So the primary focus now is on ensuring the sustainability of these efforts. Our grantees, contract, and AHRQ are exploring ways to establish practice for long-term success, to identify health system support to ensure sustainability, and to utilize policy levers such as incentives, direct-to-consumer awareness, and the clinician education. Next slide, please. In September 2024, 2 months ago, AHRQ built on the insights gained from all the EvidenceNOW projects by launching a new healthcare extension service initiative. This initiative aims to accelerate the dissemination and implementation of patient-centered outcome research evidence into healthcare delivery. These efforts will enhance healthcare policy, align payment systems, and promote community engagement among underserved populations through collaborative statewide and regional partnerships. Today's research is foundation for tomorrow's healthcare. As we advance scientific efforts to transform healthcare and to meet community needs, AHRQ will continue to play a pivotal role in disseminating and implementing actionable knowledge through research innovation and collaboration. Thank you. Elizabeth, back to you.
Thank you very much. All right.
Transforming urinary incontinence care through guided implementation. Empower. Gautam Rao, MD, University Hospitals Director of Family Medicine, Empower Co-Investigator. Grace Pelfrey, BSNRN, Clinical Research Nurse Coordinator, Empower Nurse Navigator. Logo, University Hospitals Urology Institute.
It's really helpful, I think, to have that extra framing for the initiative and how it's situated in AHRQ's broader portfolio. All right, it is time to turn to our team presentations. We will be hearing first from the Empower team. So I am pleased to introduce Dr. Gautam Rao and Grace Pelfrey. Dr. Rao chairs the Department of Family Medicine and Community Health at University Hospitals of Cleveland and Case Western Reserve University. And Ms. Pelfrey is a nurse navigator for the Empower study, whose research activities have included a focus on gender care, medical devices, and women's urological health. The team will be sharing some insights on how they've transformed UI care at university hospitals through guided implementation. As a quick reminder, please be submitting your questions through the Q&A function. I know at least one person has already found it, so that's awesome. We will have a little time after this presentation to do some quick clarifying questions, as well as more time at the end of the webinar. So let me turn it over to Dr. Rao and Ms. Pelfrey.
Okay, thank you, Elizabeth, and thanks to everyone for making some time this afternoon to join us. So as Elizabeth mentioned, this is Transforming Urinary Incontinence Care Through Guided Implementation. I'm going to speak primarily about the ECHO model and how it was incorporated into our study. And Grace is going to talk about our care pathway and nurse navigation in particular. So next slide, please. So as an overview, we are implementing Empower across a large network of primary care practices here in northeastern Ohio. It's a region of probably about more than 100 practices that we have and about 2 million patients total. And the strategies are, first of all, to target our providers as well, but empowering patients with knowledge and options to better manage this problem. So we have some significant partners. So I'm co-PI with Dr. Adonis Hijaj, the Primary Care Institute, which is the network of practices, our urology department at Case and at UH, and of course, population and quantitative health sciences as well. So the intervention component includes UI education, which I'll speak about, nurse navigation, which Grace will talk about, as well as our pathway. We also have a high-tech component, an AI chatbot, that is what is found in one of our intervention arms as well. Next slide. So here is the need, and it's been a challenge for a very long time, and I've been involved in this for a long time, is how do you educate primary care physicians about something new or something for which there is an identified need, including urinary incontinence? Because I was one of them. I am a primary care physician and I practice. And my management of urinary incontinence was pretty rudimentary. I mean, it consisted of a couple of the newer medications, perhaps a little bit of advice on fluid management, and maybe a referral if none of those would work. But it was nothing systematic. It was an incidental type of thing, because as a primary care doc, I knew I had patients with multiple chronic illnesses, and urinary incontinence was quite, even though it can have a substantial impact on the quality of life of women, was pretty far down that list. But you need to provide that education in a way that meets the schedules of busy primary care physicians. They're not going to take a day off to do a UI course, for example, somewhere, unless they have a very special interest. And it has to be something that resonates with them, and usually case-based discussions and interaction with their colleagues leaves a much stronger impression than a more traditional didactic CME. So the second part of our implementation need is we need a strategy to manage this problem that's systematic and evidence-based, and Grace will spend more time talking about that. So here are some of the things that we have to do. I mean, from the education standpoint, incorporating education into the schedules of our primary care physicians was a priority. So we use the ECHO model, and if we could have the next slide, please. So ECHO stands for Extension for Community Health Outcomes. Some of you are very familiar with ECHO. It's been around for more than 20 years now. It started in New Mexico to educate rural New Mexico physicians and other providers about hepatitis C management, because at the time, the only option was to refer patients to Albuquerque. And of course, in a very rural state, that's very difficult, very expensive for a lot of patients to get to. So up-training primary care physicians in these small communities was the strategy that was employed. So we partnered with ECHO Chicago. I've been engaged with ECHO Chicago since 2012. I used to be at the University of Chicago to design and deliver an ECHO curriculum for our primary care physicians, specifically on urinary incontinence. This was a collaboration that involved our own experts as well as the ECHO model. The actual implementation and management was through the University of Chicago. Next slide. So ECHO for CME, it could take many different forms. Fundamentally speaking, the form that I have used, and I've designed 3 or 4 different ECHO curricula. This one was actually by our UI team, in which I don't have any specific expertise. But usually you'll start with a didactic session, not more than 15-20 minutes. And then there is a case-based discussion. The cases can be presented by the didactic presenter, or they can be volunteered by the actual attendees as well. And you'll notice if you look at the curriculum, these deal with very, very fundamental issues, understanding urinary incontinence, prevalence with Dr. Pope, then Dr. Hijaj, our co-PI, will talk about evaluation, distinguishing urge and stress incontinence, for example. Then we talk about management. And this is really, I think, where the greatest need is met for our primary care physicians. As I said, I know as chair of the family medicine department and having a number of providers, their management of UI until Empower was implemented was rather rudimentary. So it was just basically some handouts, basic education, and medications, but not in any systematic way. So our curriculum actually talks about behavioral changes more systematically with Dr. Conroy, medications, and then management of overactive bladder, et cetera, and advanced management techniques to which people would have to be referred, which includes surgery as well. So it was a stepwise fashion. So the goal was that once you went to one session, you wanted to learn more. You wanted to know what the next steps would be, or what you would do for more severe cases. And so that made it more engaging for people to participate on a weekly basis. Next slide, please. So if you look at outcomes, and these outcomes, I think, are should be taken with a grain of salt. And they're often, it's very difficult to measure the impact of any educational program, because the people who participate and volunteer for them, of course, they're going to be more motivated to learn. But nevertheless, I think there's no doubt that we had a significant impact. I think in terms of management of UI, this is the first panel on the left-hand side of the slide. You can see that the number of people that pre-series improved, became competent or very competent, was quite high. And this has been the experience of ECHO curricula for a number of problems. I've led ECHO curricula in cardiovascular risk management for various problems, adolescent hypertension, pediatric obesity, etc. And you'll find that people do improve their knowledge substantially afterwards, and that they are more likely, not only that, it's not just their perception of it, they're more likely to make a diagnosis and to actually manage the problem and to refer patients on. So the key part here is that more than half, 65% or more, felt competent or very competent after completing the course versus only 15. So that's a substantial impact. And if you look on the right-hand side of the slide as well, this is really important. So let's say that you don't improve your knowledge tremendously, but you're still bringing up the issue. At least you're aware of the problem as a significant one, and that has also substantially improved as well. Okay, so next slide, please. I'm going to turn things over to Grace Pelfrey, one of our nurse navigators, who's going to talk about our care pathway and nurse navigation in general. So Grace, please take it away.
Thank you, Gotham. Yes, I'm going to introduce the care pathway. This was an interventional tool that was created by our research team and used by the nurse navigators. The images here show kind of the beginning of our care pathway, and this tool acted as a guide for nurse navigators to follow and provide education and support patients with symptoms of UI. Step 1 and 2 on the left here kind of go hand in hand. The patients would complete the ICIQ at their primary care office, and this is a questionnaire that was used to evaluate the frequency and severity of urinary incontinence, as well as the impact on quality of life. And after enrollment, the nurse navigator would review this and the patient's symptoms, have a discussion with them to determine if they report primarily stress urinary incontinence, urge urinary incontinence, or a combination of the both with mixed UI. We would then continue to review behavioral and lifestyle changes and other therapy options along the way. Next slide, please. Here you can see our full care pathway laid out. On the left is for stress urinary incontinence, and the right is urge incontinence. Step 1 would occur in the nurse navigator and the patient's first discussion, and would include taking a history, reviewing their symptoms, and what interventions they had tried in the past, what did and did not work for them, and education on potential causes were provided, and as well as common terminology. Step 2 is where we would start to introduce patients to behavioral modifications, and this might include completing a bladder diary so that we could assess their fluid and diet. We would begin reviewing pelvic floor exercises and start working on lifestyle changes such as smoking cessation, weight loss, and bladder training. Typically, in our first discussion with the patient, we would probably introduce about 2 behavioral modifications for them to work on. And the care path that we used had resources for each topic directly linked to the tool. And these could be reviewed with the patient during the discussion, or they could be shared with the patient afterwards for them to review on their own time. And with each following discussion, the nurse navigator would review if the recommended interventions had been utilized. We would assess for improvement, reinforce recommendations and education as needed, and then we would continue to further advance along the care pathway and educate patients on additional therapy options such as pelvic floor physical therapy, medications for overactive bladder, urinary incontinence devices, and surgical procedures. And then referrals were made to specialties as needed. This might occur if the patient was utilizing the interventions, but they were not seeing improvement, or for other reasons such as reporting symptoms of prolapse or maybe pelvic pain or chronic UTIs. Next slide, please. So to replicate or adapt this tool in other healthcare settings, some essential points that others would need to know is that the tool is designed for ease of use and requires minimal technical expertise. So this makes it accessible for staff who might not be tech savvy and ensures that healthcare providers can use it without any extensive training. And our care path was initially developed for UI, but the format can be adapted for various conditions and still ensure a consistent supportive experience for patients with different healthcare needs. And healthcare systems can tailor the tool to align with their specific resources and practices. So they can customize contact information or the resource links, the list of provider referrals, and educational materials. The pathway could also be presented to patients as a roadmap showing the multiple steps and the possible solutions. And this could help to frame the treatment as a journey that takes time and consistency and help them to set realistic expectations. Next slide, please. So my role on the Empower study as a nurse navigator was to support women with urinary incontinence by educating them on symptom management through behavioral and lifestyle modifications. I would connect with participants virtually 4 times over an 8-week period, and we would conduct our sessions over Zoom or over phone. And they would typically, the sessions would last between 10 to 20 minutes. And my core responsibilities included discussing treatment options, reviewing the patient's history and current symptoms, providing coaching on pelvic floor exercises, fluid and diet modifications, weight loss, smoking cessation, and I would develop individualized care plans and report urgent findings when needed or refer them to further treatment when necessary. Next slide, please. So this slide shows a bit about how we documented progression with each of our virtual meetings. The meetings occurred at approximately week 1, 2, 4, and 8 after enrollment. And we would review and document whether or not the patient followed the recommended interventions from the previous meeting before moving forward with new ones. So you can see that here in the picture on the left. And for each new session, our documentation included topics that were and were not discussed, issues or topics that the patient had brought up on their own, what educational materials did the nurse navigator provide, and what recommendations did the nurse navigator give, or what coaching was given. So you can see an example of our documentation here on the right for that. Next slide, please. After working on this project, a few challenges that I identified were that the virtual setting could lead to reduced patient engagement, especially if patients are uncomfortable at all with technology. Balancing the flowchart standardized approach with personalized care for each patient's unique situation. And also, without regular follow-ups, some patients did not utilize the recommended therapies consistently. And for the study, we had structured visits, while in other healthcare systems, the staff utilizing the tool may likely check in more frequently, where we only had the 4 time points to discuss with our patients. And some patients faced difficulties using the virtual educational resources or the virtual meeting platforms, which occasionally could lead to incomplete sessions. And reflecting on the project, one potential aha moment was just realizing the importance of building trust and creating a safe space for patients, especially given the sensitive nature of urinary incontinence. And again, the importance of using the tool as a guide and making sure to adapt the pathway to meet each patient's individual needs. And some advice for someone in a similar role in another healthcare system implementing a tool like this would be to ensure that there's flexibility in the plan and to make sure to promote an open dialogue, especially in virtual settings where building that meaningful relationship can take extra effort. Also, ensuring that if you're using a tool like this that's virtual, to make sure that you have guidance for the patients available. Our project, like Gotham mentioned, did utilize another virtual element called CC. This was an interactive chatbot that was used by some of our patients for 8 weeks. And by having these guides that we could provide to patients, it really helped them kind of utilize that tool throughout the process. Also, implementing reminders or follow-ups to track the patient's adherence and monitor their progress would be helpful, and patients would likely have better results along the way with those reminders. And making sure to engage with other healthcare providers when needed to ensure thorough care. Next slide, please. So as a nurse navigator utilizing the tool on Empower, I would say the most positive aspect was that the flowchart really helped to enhance our decision making, and it clarified the options for the patients, which really helped to reduce their stress and help them to feel less overwhelmed when considering treatment options. And a challenge that occasionally would pop up is that some of the information on the pathway was not always relevant for patients with more of a complex case or a complex history. And in some cases, patients had already exhausted a lot of these therapies and were in need of more help from a provider, and maybe were a bit reluctant to utilize some of our behavioral options. As far as patient feedback, patients really appreciated the clear step-by-step guidance for managing UI and really liked the progression of the education from the less to more invasive approaches. Many patients really preferred behavioral and lifestyle changes, as well as the pelvic floor exercises that they could utilize from home. And the verbal teaching from the nurse navigators, followed by the reading materials and the visuals and the concrete goals, was definitely highly effective. And patients who did seek further care with urology or pelvic floor physical therapy, they really valued learning about their condition and what potential treatment options were out there before seeing their provider. This kind of helped to make their visit with their provider run a little bit smoother, and they could already have some questions prepared or have an idea of what to expect. So they really got the most out of their visit. And just some occasional challenges patients reported. Again, sometimes unfamiliar being with technology was a struggle, and then attending the multiple sessions and following the behavioral and lifestyle changes consistently, just due to busy schedules or just forgetting about the interventions without regular check-ins. And then finally, we have some patient testimonials here on the slide from some of the patients we worked with through nurse navigation. Thank you.
Thank you very much. So I hope everyone will join me in thanking both Gotham and Grace for a wonderful presentation. We do have time, I think, for a brief Q&A. So I am going to introduce my colleague, Jamie Adler, who's a senior manager here at Academy Health, who will help facilitate this portion.
Everyone, thanks Empower team. That's wonderful. It was wonderful to see the patient testimonials as well on those slides, talking about a sense of control and even sharing with their friends what patients have learned. That's really exciting. We had a few questions coming in through the chat, and you're getting some kudos in the chat as well. If folks have other additional Q&A, feel free to drop those in the Q&A feature. If we don't get to them sort of in this brief intro Q&A, we'll have more time at the end as well for questions. I think you had touched on this, Grace, that the nurse navigation interaction was completed virtually. So that was all done over video or Zoom, as well as telephone call. We had a question come in about how you define bladder training. And I know LSR put a nice link in here to yourpelvicfloor.org. I don't know if there's anything else that you want to say about how you would define bladder training.
Yeah, thank you, LSR, for providing that. Bladder training was another kind of like a behavioral intervention where we would help patients kind of get in sync with their typical bladder schedule. This was helpful for patients with urge urinary incontinence and overactive bladder, where maybe they're going to the restroom, up to 15 times a day, something like that. And they might be going to the restroom every hour, every half hour. So we kind of help patients identify what's their typical schedule. And then we teach them how to kind of expand the time between their bathroom breaks by using urge suppression techniques. These utilize techniques like distraction, some pelvic floor exercises that can kind of help calm the bladder. Other things like positive affirmation, kind of talking themselves down, because when we tend to focus on what we're feeling with our bladder, we get a little anxiety, and that can actually increase our bladder activity and worsen our urge incontinence. So we kind of work with patients. It's another behavioral technique where they can do it completely from home, and it works differently for every patient. Some urge suppression techniques work really well for some patients, while others, have better luck with something like pelvic floor exercises. So that was a technique that a lot of patients really had success with.
Awesome. That's great. Two questions kind of related to more about workflow here. The first one being, in what ways were patients' primary care providers kept in the loop of what nurse navigators were doing with patients or patient progress over time?
That's a good question.
Thank you. Sorry, Chris, I can take that because I obviously have not only a co-PI the study, but I have patients enrolled in the study. So first of all, I think we did an outstanding job as a team engaging primary care physicians. And of course, that is a huge challenge. So it wasn't as if primary care physicians weren't aware of the study. Your practice had to enroll in the actual study. We enrolled people in 3 separate ways. So everybody should have known, not just the physicians, but the staff in each practice, that they are part of the Empower study. Second thing is we have a notification research enrollment system within EPIC, for example, which applies not just to Empower, but for other studies in which I'm involved. It just tells me my patient is enrolled in the study. And I think third, we do get some reports back to the physicians about, satisfaction, improvement in symptoms as well. And of course, if the patient is going through a nurse navigation, and there's a point that at which the patient, requires a referral or some other treatment is recommended, that information is given back to the primary care physician as well. So there's multiple touch points with them, not just one.
It's so important to have that feedback loop. Last question here before we move on to our next presentation. In terms of the level of interaction with nurse navigators, I think, Grace, you might have touched on this, but what was the average amount of time you spent per patient? And just thinking about that in terms of feasibility, building this into an existing nurse navigator role.
Yeah, so our sessions typically lasted between 10 to 20 minutes. I will say they were most likely more on the 20-minute side of things. And that tended to work out pretty well for patients, especially with their busy schedules. We were able to provide them a summary of everything that was discussed during our session. And if we touched on something but weren't able to have a full discussion about it quite yet, we would still provide them with the educational resource so that when we came back in our following meeting, we'd be able to touch on it and they'd have a bit of an idea about it. So the 20 minutes was kind of about the average, and I felt that that worked pretty well for our patients. I would say it would probably be feasible to build this into someone's existing role. It kind of depends on how often the check-ins occur. For the Empower study, we only had 4 meetings with each patient, and in another healthcare system, they may be able to have maybe like a monthly meeting or every other month, something like that, where they're able to see a patient more frequently. So I think it could be built into an existing role, but it really depends on the patient volume and how often the check-ins would occur with them or the discussions.
Thank you so much. I will turn it back to Elizabeth. Thanks, team.
All right.
Urinary Incontinence, UI for Women Veterans, Increasing Access to Care, Pursue Team, Elaine Markland, DOMSC. Janice Phillips, BS, Kayla Reinecke, CRNP, WHNPBC.
Thank you to Jamie and the Empower team. And we'll see all of them again in a few minutes. But next, it's my pleasure to introduce the Pursuit team. So we will be hearing from Dr. Elaine Markland, Janice Phillips, and Kayla Reinecke. So Dr. Markland serves as principal investigator for the Pursuit Project and is professor of medicine in the Division of Gerontology, Geriatrics, and Palliative Care at the University of Alabama at Birmingham. Ms. Phillips is a program director with the Department of Medicine at the University of Alabama at Birmingham, And Ms. Reinecke is a certified registered nurse practitioner at the University of Alabama at Birmingham in the Geriatrics, Gerontology, and Palliative Care Division, and in the Geriatric Research, Education, and Clinical Center at the Birmingham Veteran Affairs Hospital. Both Ms. Phillips and Ms. Reinecke serve as practice facilitators on the Pursuit team, and this team is working to improve UI care for women veterans. So I will turn it over to the Pursuit team.
Thank you so much. And I just wanted to say huge thanks to AHRQ for funding this grant and for our VA leadership in really allowing us to come in and be able to deliver what we're going to talk about today. And there are two other people on the call, Kate Davis and Hannah Howell, part of the team that have been instrumental in all the data and enrollment. And so thank you so much to everybody. And my partner in crime, Dr. Camille Vaughn, who hopefully is on the call. She is my multiple PI, and we'll get to that next slide. And so here's Dr. Vaughn and myself. Dr. Vaughn is at the Atlanta VA, so we partnered together, and we've partnered together over many years to provide behavioral treatments for our women veterans through both the Atlanta VA and the Birmingham VA. And so this project, though, is so unique because we've done behavioral treatments, and we're trying to increase access to care for behavioral treatments. But this really is a wonderful new turn to also engage primary care practices. So our overall goal was not only to increase access to care, but also to engage primary care providers and women's health clinic that serve women veterans in their health care. Next slide. So you may be thinking, wow, what is the VA? I thought that, what are the numbers of women veterans in the VA? And as you guys know, that's the largest integrated healthcare network in the United States. It really has a lot in terms of access, advocacy, outcomes, and excellence because of the integration. And we are so fortunate to see huge increases in the number of women veterans that the VA serves from a primary care perspective. That number has actually reached 10,000 and is expected to grow exponentially over the next 20 years. Of these women, though, we hypothesize that at least 30% will have incontinence. And I think women veterans are a unique population. They have unique risk factors. They have unique co-factors that really make their struggle a little different than other women who haven't had any service obligations or been in the service. But that being said, we really did decide to hone in to our current network. So part of the VA is divided into Veterans Integrated Service Networks, or VISN, and Dr. Vaughn and I are both in teams are located across VISN 7, which is Alabama, Georgia, and South Carolina. Next slide. So our practice level intervention was really has several components, and one of the biggest components is just housing all of our materials on an accessible SharePoint site that anyone can reach from any clinic or location in the VA within the VA system. So on the SharePoint site, we have lots of education that we've delivered. We've also have information on how to screen for urinary incontinence. And unique to this program, we pulled real-time data out of the electronic health record for women being seen across our VISN, so Alabama, Georgia, and South Carolina. And you can drill down into the provider panel level, clinic level, and look and see what your current rate of incontinence and other lower urinary tract symptoms are among women veterans. So not only can you see the current rates of diagnosis, you can see changes over time, and you can also see some risk factors. And not only that, it gives you real-time access into whose appointment's coming up and what their risks are. Along with all of that, we also, for a subset of clinics, we kind of randomized on this one point, as an implementation factor is that everyone got the first 4 big bucket items, but only about half our groups got our clinical pathway information. So they got information on really pointed information on where to find the referral in the electronic health record. What does this referral look like? And in this referral and pathway is a box that you can use to check to our intervention on behavioral intervention. So next slide. And that is really unique to women veterans and to this project is a VA supported mobile health application called My Healthy Bladder. And in this mobile health application, it is very VA-centric, where we really deliver an 8-week program dedicated to behavioral treatments for urinary incontinence. This program is unique that you can see it combines all these different behavioral treatments and strategies. It also educates on how to do pelvic floor muscle exercises. If patients want, they can interact with our team throughout this process. And most appreciated from the veterans themselves are actual patient stories from real patients and then inspirational quotes. And so this is our patient level intervention that is also very much related to our clinic level. So in our clinic intervention, we very much educate them on what this is. If providers are just aware of it, and if women veterans are asking about it, it's just so everyone is in the know. Next slide. All right, so our approach to implementing our provider and patient level interventions was really being able to randomize clinics based on their size. So you can imagine with only 10% of the women or veterans being women, that not all clinics have huge numbers. We have very dedicated clinics in our region that just see women veterans. So there was a range of what clinics we had in our service area. And then from these clinics, we really asked, how can we help you as providers? So following on the theme of empower, how can we take out some of the burden from the primary care setting? And we asked providers if we could send letters directly to their patient panels. We made sure they had flyers up in their clinics. We went and asked for site champions to help us make sure that they were getting all they needed from our team to help engage women veterans with incontinence and provide treatment through My Healthy Bladder. And then throughout this project, 6 months, we touched and gave them feedback from their diagnosis codes and also feedback on the number of women veterans that were engaging with us. So next slide. And then throughout this study, and even before we started, we did lots of very VA-specific educational materials. And prior to launching at any of the clinics, we definitely had high-level involvement from primary care leads at the facility level. We had primary care and women's health leads at clinic levels. And throughout all of this, we would also make sure that they had the tools they need to interact with us and our team. Next slide. And so even though this is mentioned as a roadblock, this is also a facilitator in some ways, is that even though we found that a lot of providers maybe not engaged with using this data dashboard, that as a practice facilitator, we were able to actually provide feedback and show the practices themselves what was going on at the individual level. And so it really did end up being a very powerful tool, at least from our facilitation and implementation team. And then some of the clinics really adopted it, whereas others just knew it was there in the background. Next slide. And a little bit more on wins and woes. We really, in the last year of this award, ramped up. You can see our recruitment of the number of women who used My Healthy Bladder. And so as we started ramping up the number of clinics, we recruited 60 clinics across the region. We and we mailed over 37,000 letters. And some sites allowed us to also send direct emails. And through these two mechanisms, we were able to enroll 3,200 women veterans. And you can see that steady increase over time with what we projected and what was actually happening. And I'm really thankful for the team. Without their huge amount of effort and persistence in getting out letters and the recruitment efforts, we would have not been here. But I will say it's amazing how many women veterans do open mail, whether it's email or snail mail. Next slide. All right. So just some key considerations before I turn it over to Janice and Kayla. We just really, with an integrated healthcare system like the VA, it's very organized by primary care leadership. And so at every facility, there's primary care leads, and not only from a primary care leadership perspective, nursing staff. The nursing leads are instrumental in making sure that we can get the message out there. Many times it's nurse managers that are going to all the clinics to deliver education about new programs, and then also engaging just at the clinic level and making sure there's a champion. So it takes multiple levels, multiple touches to get the uptake that we need. And I'm just so thrilled that we were able to be able to do that. But I want to turn it now to Janice and Kayla to give us a really more in-depth look at that clinic level implementation from a practice facilitator standpoint. Next slide.
Implementation in action. Janice Phillips, Practice Facilitation Coordinator. Kayla Reinecke, CRNP Women's Health Nurse Practitioner Implementation Specialist.
Hi, I'm Janice Phillips, and my background is recruitment and retention on clinical and community-based projects. So with this program on Pursuit, I was the practice facilitation coordinator, where I did strategic planning for recruitment and engagement with the clinics. So based on that, my core responsibilities included working out the logistics, helping to identify site champions, and also trying to ensure that we had more than one contact per site. So how do we really interact? So I'm going to tell you however we could really get in touch with them. If that meant in person, we would be in person. We would meet via Teams, a lot of telephone calls, a lot of contacts to get to the initial visit. So my goal was just really to work out the logistics for setting up the initial meetings. And I'll turn it over to you, Kayla.
Hello, my name is Kayla. I am also Janice and I, part of her team implementing the project. The one piece that I would do is, after Janice made the initial contact and got the high level group on board, she would, like she said, she would get the education portion ready to send out to them. We would set up that initial meeting, and then once a group was put on board, they would give me the site champion, and I would take over from there and monitor and help walk them through the program over the next 6 months. Next slide. So our preliminary data when we implemented this project over the 6 months showed that we were increased the LUTS diagnosis by 2 to 6%. And our site champions were very excited when I was able to provide them with this data and show them how they progressed. We would do big reports, send an email. I would get on the phone and talk with them. So it was nice to give them hard numbers, and that was possible because of the data dashboard. Sometimes we found a site champion that just wasn't very much excited about the program. It was very rare, but we just needed to usually re-educate them and re-engage them at the 3-month mark. And a lot of times that was a great opportunity for us to re-engage with them about the My Healthy Bladder app, and we would see the numbers go up again from there. So that 3-month engagement was very timely. our providers and our staff were very receptive to having treatment for UI. A lot of them heard women veterans complain about this a lot. We weren't exactly sure how to deal with it other than giving them a medication. So the idea of introducing behavior treatment and them being able to do it at home was feedback that we got from the nurses and the site champions that was major for them. And I would say the biggest part of the implementation process was just being able to connect with the site champion and build that relationship so that they knew they could contact us with any questions that they had or get them the information that they needed. Those touch points when we did the 3-month and the 6-month follow-up, that was always a good time for me to really hear what was working and what wasn't working, and then come up with ideas on how to increase their numbers, so to say. Next slide, please. So this slide, I think we were trying to say from the implementation view and action, from the clinic staff ranged from them not being very engaged to being completely engaged. So it was kind of all over the board. And then having that site champion was just the major key factor, having somebody that I could put my, an email to, a face to, or even just a name to contact to say, how's this going? Sometimes just to remind them that there was a program out there for them to use. And I know that our women veterans loved it. We were still going through all that data, but preliminary data suggests that they were very excited to use the app.
Thank
And
you.
yeah, we can answer questions now.
All right. Thank you so much. So we have now had 2 awesome presentations, which is fantastic. So everyone, please join me in thanking Elise, Janice, and Kayla for their presentation. I'm going to turn things back over to Jamie to do some quick Q&A just with respect to this presentation, and then we will pivot and do a larger discussion that brings both teams back together.
Awesome. Thanks, Pursuit team. This is great. If folks have Q&A, feel free to drop them in the chat. We will answer a few questions for the Pursuit team, and then, as Elizabeth said, open it up for some discussion and questions for both teams. Curious, you mentioned the clinic champions really being, your go-to point of contacts at the sites, particularly when you couldn't sort of have touch points or other folks weren't as engaged on the front line. What was it about those clinic champions, or what was the role within the health center, and maybe it varied, that you feel like really motivated those clinic champions to want to engage?
Yeah, so the role was sometimes different, but almost all of them were nurse driven. We had very few providers that wanted to be a site champion. We would always ask during that initial education, does somebody want to be my partner in all of this? And it was almost always somebody from the nursing team. It could be nurse management, it could be even nurse leadership that saw several clinics. They might head up 1 or 2 clinics. And I think what kept them engaged is probably just our persistence in engaging them. That was the critical thing. And I think being a nurse myself, I was able to communicate nurse language and, one-on-one with them about what's working, what's not working. I understood that their days were crazy. I understood that nobody wants one more box to click. I understood that they can't make anybody do this. I understood all the different things that they would tell me are going wrong, but we anticipated a lot of that, and our toolkit was tailored to answer a lot of those anticipated barriers, so that would make things very easy on them to intercept. We were just basically asking them, just ask everybody those IC/IQ questions, and if they're positive, give them this brochure. It has a QR code. They can scan it and get logged into our My Healthy Bladder, and we'll take over from there. And that made things so much easier, but getting that message across to them was the hard part sometimes is getting it drilled down to that. We had to explain why it's important. And you're talking about a predominantly male integrated system, talking, you know, in primary care, some of these people didn't see but maybe 200 women ever. And, you know, and at a facility that saw like, you know, a couple thousand men. So, you know, we weren't talking about a big portion of some of their patient population.
Yeah. And for folks, the ICIQ was your screener questions,
Oh,
correct?
yes, I'm sorry. Yeah, they're just two simple questions.
Awesome. Great. You had also mentioned sort of some adaptation for sites. You were meeting with sites, what's working, what's not working. Can you talk a little bit about any adaptations you might have made so that you could tailor for sites in particular that might have been challenged?
I'm thinking back. So we always went after this is the program, here's everything we can offer you. You know, this is an implementation process. It's not going to be perfect. There's no pressure. We're here to help you, you know, get more women involved in talking about this and getting them treatment. So everybody was on board from then. About the 3-month mark was when we would meet and they would say, I don't know, I haven't been as engaged as I should have been, or, you know, what am I supposed to be asking them again? Sometimes we would have people ask questions again. And so sometimes it was more of a re-education of everything. Other times it was just, you know, they would come on and they would say, I want to get women this help, but I don't know like how to get them access to, you know, your clinic or the ones that were randomized to our clinic. So some of them, you know, we talked about including the link to the clickable where they could click in and contact our clinic to take care of those patients. That's an easy way to get women care. Provider just wanted to do a quick click and send them on over, not worry about scanning any QR codes or anything. It truly just depended on each site. But I feel like we were really well equipped to give them what they needed when they needed it. I tried to let the site tell me how things were going. And then I tried to just fill in the gaps with, well, here's your numbers now. Here's where you know, we think you could do a little bit better. Here's what we've helped. Here's what you've done. Why don't we try engaging with this? But yeah, they were all pretty engaged. It was getting them on the phone that was the main thing. On the phone or face to face and virtually, that was the big difference. If just sending emails out at critical points, that didn't really help a whole lot engage. So I would say building those relationships is honestly the key. You have to have the relationship to know what's going wrong, so that you can provide a solution or help them get what they need.
Spoken like a true practice facilitator. That's great. That's great. In terms of sort of outcomes, you talked a little bit, there's a question in the chat, and I had a similar question. You talked a little bit about you're sort of going through the data now, and I know you're kind of in the analysis phase, so you won't have a complete answer for this, I don't think. But kind of getting an understanding, it sounds like women really responded to this intervention, and I'm curious if you can share a little bit more about any findings you have there, maybe quantitatively or qualitatively.
I'm going to hand this over to one of my other teammates. I have not been a part of hearing what patients are actually saying. I'm just hearing from the nurse's standpoint that they've enjoyed using the app. But I'm going to let somebody else say that. I don't know that we know that.
I mean, we haven't even collected all of our data, but some early data looks do show that we are making improvements in incontinence severity. The question really is about restored continence. I think that's the elusive part of anybody who practices in this field. Is restoring complete continence is always the goal, but doing that is much more difficult. And I will say behavioral treatments have shown to have significant improvements in symptoms in their first-line treatments. So it's always a good place to start, although they may not restore continence. We have really good signals that incontinence severity improves on validated index with My Healthy Bladder.
Great. One more question here before we turn to a larger group discussion. Thinking about the different ways that clinics did UI screening. And so if any sites integrated it into the usual screening practices, so I'm thinking like cancer screenings, other sort of preventative screenings, and if those sites were any different than sites that might have had it sort of as a separate intervention, if you know.
Yeah, I can actually talk about this. So we had very few sites that used it as part of their pre-screening. And I had a lot of conversations around this with lots of different nurses, because I think there's only one major organization out there that suggests screening at women's appointments. I could be wrong, but it's kind of hard to find evidence that says screening helps with incontinence. Or helps prevent incontinence. So part of I think our program was trying to look at, if we can we screen people, and getting the clinics to screen people and how they wanted to approach that. Did they want it being done with a questionnaire at when they were checking in on a piece of paper? Did they want it done at the triage level with the triage nurse? Did they want it done, in the provider's room and the provider asked the questions? That was always the when I would do the baseline with the site champion, we would discuss those things. How are you planning on screening all these patients? What do you kind of want to think about adopting? What would be easiest for your clinic? And they were all different. They were honestly all different. And I think that's because we don't have a massive, push from a major organization saying screening women at every visit for urinary incontinence can prevent it. But I did have lots of people come back and ask if they could include it on their checkoff screen, the nurses' checkoff screens, and we're at the VA, that's a lot harder or easier said than done, I should say. It's very hard to get a form changed. We did look into it a couple of times. We just heard that it was way above the level that we were kind of implementing right here for now, but that it would be considered later.
I have heard talk at a national level from women's health groups that they are considering adding it to their screening questionnaire. And I've even seen some drafts of an actual question that will address this. And that's great because it takes a national level to come down to the local level and get it programmed into the health record. So I think there are some movements right now. I've seen some signals.
Great. Yeah, we need sort of top down and bottom up at this point. Good to hear. Keep your questions coming. I see a few more in the chat that we will get to as we go here, but wanted to welcome the Pursuit team back as well into the conversation. So feel free to come on camera and come off mute. We wanted to sort of open this up for a broader discussion. Obviously, these are distinct interventions, but with very similar goals of screening and treating women with UI in primary care. And so wanted to have a little bit of cross discussion as more questions come in from our audience here, kind of about the implementation that you all have seen to date. Just for everyone on the call, the trajectory of these projects is still in progress. They are still, tail end of wrapping up their projects. So more data will be emerging as we go. But sort of thinking about, we've talked a little bit about patient input and the impact you've seen on patients. I'm curious if you all, how you might have incorporated patient input as you went on this project, either at the beginning of the project or sort of throughout, if there was any sort of touch points that you had with patients or any ways that you ensured that your projects were patient-centric.
Jamie, I can start with a couple of comments, and I'm sure Grace and Elazar have something to add too. We do have a stakeholder panel that meets regularly. We actually had a meeting, I think, Elazar, not too long ago about it, that includes a number of representatives of UI organizations, clinicians, but also patients as well. And and we actually had quite a bit of valuable input on designing our recruitment flyers and our questionnaires from patients. Actually, we wouldn't have made some of the changes without their specific input too. I think from a personal standpoint, communicating with patients about urinary incontinence, a lot of the information has come from patients. Well, how do I even raise this issue? Because this is one of the biggest things. There's stigma associated with it, etc. You know, if you simply wait for women to raise this as an issue, it's not going to work. So at least in the underserved population I deal with. So we've gotten some input about that too. What do I say? What questions do I ask? Beyond the usual screening questionnaires, you know, to gauge the severity and their interest in treatment. So in summary, I think we've got a panel. We're always open to patient input as well, whether it comes through our clinicians or directly from patients who are enrolled in the study. We've got lots of testimonials that LSR can share as well.
Yeah, definitely. Just to kind of add to what Gotham was saying, and hi everyone, I'm Elisa. I'm the project manager for Empower. I just wanted to also add that we built our database where we input all of the data from our project, just based on the ease of use for our nurse navigators to better communicate with patients in a way that is more real and less structured, even though that's really tough in a clinical trial. And as Gotham had said, we definitely utilize patient input for our marketing materials as well as patient education forms. So like he said, there was a lot of positive reinforcement in terms of language surrounded around urinary incontinence, and the stigma piece of it was a delicate subject. So we utilized very positive language that, you know, you're not alone. You should speak up about this issue because it is common, but it's not normal. So we had a lot of pointers to kind of guide patients in the right direction while also using their input.
I don't know, Pursuit team, if you had any thoughts there.
Yeah, My Healthy Bladder was definitely designed with the help of women veterans, and it's very, very patient oriented. It was also pilot tested before this trial and also compared to a telehealth model of delivery of behavioral medicine. So I will say we definitely have modified My Healthy Bladder over the years based on what veterans are telling us, and the impact of the qualitative interviews we've done over the years have really changed. Some simple things are like making the content available after the 8 weeks. You know, things about how can I engage more with providers. And so this is why the program was so timely. But yes, veteran interest groups are highly appreciated, and we need them and engage with them at all levels as well in the VA.
Awesome. Great to hear. Moving on to another question a little bit more about implementation. Both teams have talked a little bit about engaging frontline staffs. You've had clinic champions. I'm curious to hear a little bit more about, you know, what your approach was that is oftentimes can be difficult to engage folks to do a behavior that they either haven't done before, feel uncomfortable with, or add, you know, an extra sort of checklist item maybe in their minds to their plate. So in terms of screening and treatment, I'm curious to hear a little bit more about how you all worked with providers in addition to some of the more formalized education that you provided.
Yeah, I can definitely speak to what we did for Empower. So what we did was we were asking the primary care offices that joined our study project to screen all the women that came into their clinic with the paper ICIQ form, ICIQ short form. And we went into it and they were very hesitant. So frontline staff are hesitant to learn a new workflow or process that's, you know, not necessarily a metric that's required by the hospital or hospital leadership. So our screening tool really, it was not a requirement, but it was framed in a way as a quality improvement initiative. So our team had the quality improvement initiative backed by hospital and primary care leadership, which was very, very helpful in order to make it a truly important task that is added onto the frontline staff's plates, but that it is very important to follow through with. We also tried to make the workflow extremely easy to follow by
creating a document that acted like a guide for frontline staff so that they could initiate the screening process, return it back to our study team. And, once it started, it really became much easier for the teams to utilize it, the frontline staff to utilize it. And in doing so, they ended up not even needing that document tool after a few weeks of screening.
That's impressive conversion.
I will say we also, for each wave, we did kind of show our appreciation for the staff by dropping by, checking in on them and providing them with some goodies, some snacks and bagels for each wave. And it was definitely effective, showing them that we appreciated them taking the time out of their day to add in this additional task. And we did notice that after each little goodie drop off, we did notice a quite an influx in patients being screened. So that was definitely effective and helpful. And I think they really appreciated that. So any way to just kind of show appreciation for, this change that we're asking them to implement in their practice.
And I can speak from the physician angle. I think that, it was tough going at first, and I know all the teams in MUI have faced the same challenge of recruiting practices and physicians, but some of it is personal contact. So as the chair, I can reach out to people and say, hey, we really like to, but you can't force anyone to participate, but this is really important. And it gets easier after a while. It's almost like peer pressure. You've got a whole bunch of practices. Well, Dr. Smith's practice is in it, and why shouldn't we be in it as well? Sort of thing. And even patients can, apply the same sort of pressure as well, saying, well, they've got this going on, they're due have Empower. Although that doesn't happen too often, I think it kind of has a little bit of a snowball effect as well. The main source of that is, I think, people realizing that we do really want to be minimally burdensome to them. And when they participate and they say, hey, this isn't such a big deal, it's helping my patients a great deal, I should be doing it. It gets easier to engage with the practice leads.
Great. Oh, Wayne, I saw you come off mute. Did you have a thought there?
Well, I was just going to say, just acknowledging that the sites that actually met us in person and allowed us to come and/or send treats, I think were a little bit more likely to be engaged. And a big thanks to Janice for, really making sure. We also have huge folders that we would send. So we would have all the materials in both paper form as well as being able to present and just being able to deliver something tangibly, whether it was food or a pen or a magnet or just something tangible, I think was really helpful when it came to practices and getting engagement from the frontline staff.
I think there's something to that of having something in the real world that you can hold in your hand. Yeah, that's great. I'm going to turn to a few audience questions here. I know you both mentioned kind of some of the role of telehealth in your work. And the question is if you could expand a little bit about the telehealth or any sort of technology related approaches in your research and clinical care on this project.
Something. I think the VA has its own integrated healthcare system that has its own platform for telehealth called VA Video Connect. And I think it's a natural extension, and also was the only way we could see and treat women veterans during COVID. And so I can say that because of not only COVID, but after effects of COVID, that telehealth in the VA has been very much adopted, and it's been adopted for these first-line behavioral treatments for incontinence. And I think a good place to start. So I don't think it's a substitute for bringing somebody in and doing pelvic floor exams and teaching them pelvic floor muscle exercises in person. But if you can get them started and get them into a program, whether it's My Healthy Bladder or just an online one-on-one, with a provider, I think it goes a long way to being able to provide access to care to rural areas, and a great way to deliver behavioral care. And so we do it part of our clinical care. This isn't research. This is just straight clinical care.
So just broadly speaking about technology, I spoke a little bit about Echo, and Grace talked about nurse navigation. We also have a chatbot, an AI chatbot, that provides guided treatment and navigation to patients enrolled in that specific arm. So we do have a technology component incorporated as well. I think that beyond that, we didn't use telemedicine, as Elaine said, specifically for care or for clinical care. Although, you know, we do have telemedicine platforms that can be used with individual patients.
These next two questions are somewhat related. I'm going to try to group them. Thinking about, you know, how UI could relate to other maladies or maybe behavioral or lifestyle components in a woman's life. You know, you talked a little bit about sort of the behavioral training that you all did as part of these projects. You know, how much of this is related to sort of screening to behavior change? Are there other factors that you see beyond behavior change that have an impact both on UI and outcomes for women?
Yeah, I would say a good amount of our patients that were screened and enrolled in Empower struggled with mild to moderate urinary incontinence, where they really appreciated the behavioral and lifestyle changes. And by enrolling in the study, if they were really engaged with the nurse navigators and really followed up with the educational materials provided and the recommendations that were given, they really did see quick improvement, whether it was changes in food and diet modifications, just tracking, you know, minor changes, limiting caffeine, limiting bladder irritants could make a huge difference. And that could be the one thing that someone was struggling with, and they noticed, you know, maybe a 25% reduction in their symptoms within a week or so. So that, I feel like the behavioral changes, whether it was diet, exercises, pelvic floor, that was something that women really, they honed in on that. And once they kind of got the hang of it and it became implemented in part of their schedule, it kind of became easy to them, or they look forward to continuing to utilize those interventions, and they really saw the best results. So I felt that the behavioral modifications, that was definitely really well received, but the women that did, you know, maybe needed a little more improvement, needed to discuss other treatments with providers, whether it was medications or, you know, maybe a referral to pelvic floor physical therapy for further coaching. That was, you know, that was a good amount of patients too, but a lot of them really did see improvement with just the behavioral and lifestyle changes.
Well, we have some additional questions here about sustainability, but I'm going to hold that until our next public webinar, because at that point, you will all get to hear about how the 5 MUI grantee teams have sort of come out the other side of these interventions and what sustainability looks like, and the end progress of all of these interventions. So thank you so much, teams. I'm going to turn it over to Elizabeth.
Thank you, Jamie. And I'm hoping that everyone will join me in thanking all of our speakers today. So we had folks from Empower, we had Gotham and Grace, and then we had folks from Pursuit, we had Elaine and Janice and Kayla, and of course, Jamie leading the charge and helping to facilitate the Q&A with everybody. So fantastic presentations today. But before we leave, we want to share with you all about some of the resources and tools that have been developed by the MUI initiative and that are currently available on AHRQ's website. So I'm going to turn things over to Marley Catlett, who's a Senior Research Associate here at Academy Health, who is going to take us through a gentle romp through the resources available on AHRQ's website.
Thanks, Elizabeth. So as Elizabeth mentioned, there are several tools and resources from the MUI initiative currently available on the AHRQ website, and we will walk through a couple of those now. First, we have the perspectives from the field, which are written interviews with 3 MUI grantee teams, in which the teams reflect on the implementation of their initiatives in primary care settings. These interviews can be helpful for healthcare administrators, quality improvement staff, practice facilitators, primary care providers, and practices treating UI, as well as researchers, as each team provides not only insight into their experiences, but also actionable advice that can be taken to address UI. Recordings of past MUI webinars that highlight the 5 grantee projects can also be found on the website, and these may be especially beneficial for researchers, practice facilitators, and practices and primary care providers treating UI. Today's webinar will also be posted on the website. The Patient Resource Library is a web page aimed at women experiencing UI that contains resources to help patients discuss, understand, and manage their UI. And finally, the MUI Tools and Resources Library is an online repository of tools and grantee-developed resources that practice facilitators, primary care providers, and practices treating UI can use to find resources on engagement, recruitment, and retention of practices and providers. Now we're going to take a closer look at 2 of these resources. Next slide, please. So as I mentioned, the perspectives from the field provide insight into the implementation of grantee initiatives. In addition to the 2 grantee teams that we heard from today, there are 3 other MUI grantees, and each of these 3 teams are highlighted in the perspectives from the field interviews. On the website, you'll find a project overview for each team highlighted, as well as responses to a number of interview questions about their initiatives. To give you a bit of an idea of the types of insights and advice you'll find in the perspectives from the field interviews, when asked about what advice they have for primary care practices that are considering adopting interventions to screen and treat UI, the Wisconsin Intuit team shared that many of their primary care practices modeled UI screening and treatment after existing practices for depression screening. They stated that, like UI, depression is a stigmatized condition for which we rely on patient questionnaires rather than clinical or laboratory tests. Most of our primary care practices already had awesome workflows for depression screening, so piggybacking UI screening onto those workflows made sense and was minimally disruptive. Next slide, please. This slide displays the MUI Tools and Resources Library. As you can see on the left side navigation bar, you have the ability to search by keyword and filter resources by types of resources, whether that's peer-reviewed literature, patient or provider education materials, job aids, or materials developed by MUI grantees specifically, as well as other types of resources. There's also the capability to filter by topic area to help users of the library narrow results to find resources that are most relevant to their needs and contexts. Next slide. Finally, several implementation tools developed by the MUI grantee teams are also available on the AHRQ website. For example, Empower's Care Pathway, which you heard about earlier today in their presentation, lives within the implementation tools, as well as Pursuit's Clinician Pocket Guide, which outlines lifestyle modifications, diagnosis codes, and treatment options for providers. I'll also quickly highlight a few tools from other teams. The IT2 team's clinician education model presents case studies that cover current evidence-based practices for screening, identifying, and treating different types of UI in women. The Optima team used a number of clinical decision support tools in their initiative, including a best practice advisory, note templates, and smart sets. And the resource available on the website walks through each of these tools and provides some guidance on how to use them. Finally, the Wisconsin Intuit team's Practice Launch Toolkit compiles a number of resources that can support implementation of screening and treating UI, including a UI algorithm that guides providers through next steps when a patient screens positive for UI, patient education materials, EHR templates, UI screeners, and more. So all of those resources and tools are available on the website. That covers those that we wanted to share with you all today. So with that, I will pass it back over to Jamie.
Awesome. Thanks, Marley. Thanks, everyone, for sticking with us. We hope these presentations resonated with all of you. There's links in the chat to the resources that Marley mentioned, so please check those out. There's a lot of good resources, both created by the grantees specifically, as well as some overarching resources from the initiative as a whole. Next slide. So with that, we want to thank everyone for joining us today. Thank you to all of our speakers, to AHRQ, and for this team for putting this event together. For more information, as I mentioned, please feel free to reach out at any time. We can be reached at MUI_SE Center@academyhealth.org. For an easy access QR code, you can scan your phone here on this slide to find all the resources mentioned today. And at the end of the webinar, when you close out, you will see a survey pop up on your screen. We would so appreciate you taking that evaluation so that we can best suit future webinars and events to all of your interests. So thank you so much. And with that, enjoy the rest of your day.
Thanks, everyone.
Thank you.
For more information regarding the MUI initiative and to access resources, scan the QR code that points to the following URL: https://www.ahrq.gov/evidencenow/project/urinary/index.html. Additional questions? MUI_SE Center@academyhealth.org. Slide 4. 35th AHRQ Anniversary. Today's research, tomorrow's healthcare. AHRQ's mission: to improve healthcare for all by producing evidence to make healthcare of higher quality so that it is safer, patient-centered, timely, effective, accessible, efficiently provided, and equitably distributed. Working within the U.S. Department of Health and Human Services and with the states, territories, tribal nations, and private partners to make sure that the evidence is understood and used. AHRQ works, building bridges between research and practice. Infographic: 4 squares of different colors with the following text in each square. 1. AHRQ.Research for Healthcare. 2. NIH. Cures. 3. FDA. Drug Safety. 4. CDC. Public Health. Slide 5. AHRQ's EvidenceNOW initiative, a model for providing external support to primary care practices to improve care delivery, integrates quality improvement and implementation science, advancing heart health, building state capacity to advance equity in heart health, managing unhealthy alcohol use in primary care, managing urinary incontinence in primary care. Infographic: EvidenceNOW Quality Improvement Services. 5 circles with the following text. 1. On-site practice. 2. Health and support. 3. Shared learning collaboratives. 4. Expert consultation. 5. Data feedback and benchmarking. Footer: EvidenceNOW, Balancing Primary Care Implementation and Implementation Research. Myers et al. ANFAM Med. April 2018. Slide 6. EvidenceNOW, Managing Urinary Incontinence. University of Alabama at Birmingham. PI Lane D. Markland, D.O., MSc. University of Wisconsin-Madison. PI Heidi W. Brown, MD, MAS. University of California San Diego. PI Jennifer T. Anger, MD, MPH. Northwestern University, Chicago. PI Kimberly S. Kenton, MD, University Hospitals of Cleveland. PI Adonis K. Hidges, MD. Use the EvidenceNOW model of external support to primary care practices. Help 5 grantees disseminate and implement patient-centered outcomes research findings to improve nonsurgical treatments for UI/QR code, linking to www.ahrq.gov/evidence/now/projects/urinary/index.html. Map of the untied states with states participating in EvidenceNOW program highlighted. Includes California, Wisconsin, Illinois, Ohio, Alabama, Georgia, South Carolina. Slide 7. Practices and patients reached across the initiative. Horizontal bar graph with 3 bars. X-axis represents the number of practices participating. 1. Grantee goal: 290. 2. AHRQ initiative goal: 250. Actual: 254. Line graph: cumulative number of women screened by quarter. X-axis: 0 to 45,000 in increments of 5,000. Y-axis: quarters from 2022 Q4 through 2024 Q1, 2022 Q4, 2277, 2023 Q1, 4935, 2023 Q2, 7722, 2023 Q3, 13,454, 2023 Q4, 20,990, 2024 Q1, 35,147. Slide 8. Venn diagram with 3 circles. One circle describes that state-based cooperatives will use PCOR evidence to improve care for the medically underserved. One circle describes that the National Coordinating Center will provide technical assistance to cooperatives and establish learning networks. One circle describes that the National Evaluation Center will develop data, measures, and methods for assessment and deliver a summary report. The central overlap of the circles describes the goal to accelerate implementation of PCOR evidence into practice. RFAHS-24004 State-Based Healthcare Extension Cooperatives, U19. Up to 15 awards. $25 million over 5 years for each award. Application due date, January 6, 2025. RFAHS 24006, National Coordinating Center, NCC. 1 award, $14.25 million over 5 years. Application due date, December 13, 2024. RFAHS 24005, National Evaluation Center, NEC. 1 award, $14.8 million over 5 years. Application due date, December 13, 2024. Technical assistance resources for applicants. Questions, ahrqhes@ahrq.hhs.gov. Slide 10. Empower Overview. Goals. Implementation of the Empower program across a large network of primary care practices to improve the diagnosis of urinary incontinence and promote non-operative treatment. This is done by empowering both patients and physicians to remove the barriers to incontinence care. Project Team. PIS Primary Care Institute, a Urology Institute, Case Western Population and Quantitative Health Sciences. Population of Focus, Women of Northeast Ohio Region. Intervention Components, UI Education via Virtual Echo Platform, One-on-One Nurse Navigation, Evidence-Based Care Pathway, Interactive AI Chatbot via Smart Device. Slide 11. Implementation Need, Accessible Continuing Medical Education for Primary Care Providers ECHO. One that aligns with the busy clinic schedule of PCPs. Virtual and collaborative. Primary care providers need an easy-to-access tool to guide their care for UI.care pathway. Providers are not addressing complaints of UI on a daily basis. No quick, easy, and effective tool exists to identify first, second, and third-line therapies. Challenges. Creating a tool that can be utilized by anyone. Providers accepting the tool and implementing it into their workflow. Slide 12. What is ECHO? ECHO Chicago provides telementoring for community-based providers through case-based learning delivered via high-grade video conferencing. Providers gain knowledge and skills for managing common chronic physical and mental health conditions that they translate into practice with the support of their peers. Source, https://www.echo-chicago.org. Collaborative sessions with participants run by clinical experts in the field. Collective participation by attendees is encouraged. Provide case studies, questions, comprehensions, etc. Slide 13. ECHO for CME. Setting. Table, Column 1, Number. Column 2, Topic. Column 3, Facilitator. 1. Understanding urinary incontinence, UI causes and types, prevalence. Rachel Pope, MD. 2. Basic office evaluation of urinary incontinence. Adonis Hidges, MD. 3. Management of UIY behavioral. Britt Conroy, MD, PhD, JD. 4. Medications for UIY PT. Karen Connor, PT. 5. Management of UI Mosley O. David Shane, MD. 6. Advanced Management of O. Botox, PTNS, Interstim. Anna Myers, CNP. 7. Surgical Management of SU. IY Bulking and Slings. Joseph Wells Henderson, MD. 8. Complex UI How to Identify the Complex Patient for Early Referral. Rachel Pope, MD. Slide 14. Response from participants in ECHO. Bar graph. Manage patients with UI.x-axis. 0% thorough, 60% in increments of 10%. X-axis. Skill level with 2 bars for each level, pre-series and post-series. None or no skill at all. Pre 2%, post NA. Vague knowledge skills or competence. Pre 9%, post NA. Slight knowledge skills or competence. Pre 30%, post 6%. Average among my peers. Pre 43%, post 26%. Competent. Pre 11%, post 50%, very competent, pre 4%, post 15%, expert, teach others 3%, second bar graph, same axis. How often bring UI up if a patient doesn't? Never, pre 3%, post NA, rarely, pre 5%, post 8%, sometimes, pre 35%, post 20%, often, pre 3%, post 24%, most of the time, pre 3%, post 8%, NA pre 51%, post 20%. Slide 15. Flow diagram. Step 1. Identify type of incontinence. Participant has complaints/symptoms of UI. Step 2. Review completed ICIQ. Confirm predominant UI symptoms. SU, I versus UU. Step 3. Assign pathway route. Flow diagram. 2 boxes flow at the same level. First box, stress UI, SUI, leakage on activity, e.g. coughing, laughing, sneezing, exercise. Second box, urge UI/overactive bladder, UUI/OAB. Both these boxes flow into the final box, mixed UI, MUI. Symptoms of both SUI and OAB/UUI refer to both pathways and incorporate care options to address symptoms that the patient is predominantly experiencing. Slide 16. Care pathway features. Step 1. Collect history and background. Explain/review bladder diary. 1. Ever limited your fluids, kept track, etc.? If not, explain and assign bladder diary. 2. Ever tried Kegels, kept track, etc.? Teach pelvic floor exercises. 3. Ever tried medications? No, start with behavioral management. Yes, recommend medication to be discussed with PCP. 4. Ever tried pelvic floor physical therapy, PFPTI? Consider if referral to PFPT is needed. 5. Ever had or considered surgery for UI pelvic organ polyps, POP? Consider if referral to specialist is needed. Step 2. Assign behavioral options. Fluid/dietary management, bladder training, pelvic floor exercises, healthy lifestyle changes. Step 3. AS's improvement. If improved, less leakage, continue and reiterate behavioral practices, flowing back into step 2. If not, same/more leakage, proceed to step 4. Step 4. Next steps, referral to PFPT or explain device options. Vaginal pessary leads to a specialist referral, and Impressa/tampon use does not. After step 4, step 5. Assess improvement. If improved, less leakage, continue PFPT or device option and go back to step 4. If no improved, same or more leakage, refer to specialist. Slide 16 continued. Empower urge urinary incontinence pathway. Steps 1 to 5 are the same other than using medication rather than devices in step 4. Medication options. Beta-3 agonist/anticholinergic. PT not interested, refer to specialist. If interested in PT, encourage PT to speak with provider. Slide 17. Uptake considerations. User-friendly interface. No need to be tech-savvy. Can be utilized in a variety of ways, even outside of UI, to create a care pathway for many conditions. If a health system would like to use it, they are able to customize the tool to their practice, contacts, resources, helpful links, referral lists, etc. The pathway could eventually be used as a presentation to patients, so they are aware that the process of UI treatment is many steps, with many solutions. It's a journey. Slide 18. Implementation and action. As a nurse navigator on the Empower study, I supported women with urinary incontinence by providing education on symptom management through behavioral and lifestyle modifications, conducting virtual sessions over an 8-week period to guide participants through personalized care. Core responsibilities: develop an understanding of commonly reported urinary symptoms, take a patient's history relating to incontinence, assigning and reviewing bladder diary, provide written and verbal education and materials, develop unique treatment plans tailored to patient symptoms and preferences, provide guidance and resources to patients regarding further lines of treatment or referrals, offer emotional support, ensure timely access to necessary services, report urgent findings to a provider. Slide 19. Nurse Navigator documentation. Reviewed and documented patient use of recommended interventions from the previous meeting. Move forward with new interventions as per the care path and individual needs and preferences. Example assessments provided showing different selections. Slide 20. Implementation in action. Challenges, insights, and advice on the Empower project. Challenges encountered. Patient engagement. Virtual settings may reduce engagement. Tailored care. Balancing standardized pathways with personalized approaches. Follow through. Supporting patients to adhere to therapies. Technological barriers. Tech issues can disrupt sessions. Key insights. Importance of trust building in sensitive health topics. Need to adapt standardized care for individual patient needs. Advice for similar interventions. Patient-centered approach. Customize care plans. Promote open dialogue and clear communication. Tech support. Provide guidance on virtual tools. Implement a follow-up strategy. Interdisciplinary collaboration. Slide 21. Implementation in action. Reactions to the Empower intervention. Nurse navigator feedback. The flowchart helped optimize decision-making and clarified options for overwhelmed patients. Challenges. Balancing structured guidance with personalized care for complex cases. Patient feedback. Positive aspects. Clear step-by-step guidance, least to most invasive approaches, behavioral lifestyle changes, and exercises were well received. Verbal teaching followed by reading materials. Visuals help patients feel more informed and willing to see specialists, e.g., pelvic floor therapists, urologists. Challenges. Adhering to treatment plans, unfamiliarity with technology, and time commitment. Quote, I have taken the information about lifestyle changes and applied it to my everyday life. I've been sleeping through the night. I don't have urgency when I wake up in the morning. I now feel a wonderful sense of control. Quote, being a part of the study was a great and new experience for me. I learned a lot of information that I'll be able to take with me and I can share with my friends. Slide 24. Pursuit overview. Increase access to UI treatment for women veterans by approaching 60-plus primary care and women's health clinics that serve women veterans in their primary health care. Camille Vaughn, MD, MS. Camille Vaughn, MD, MS. Associate Professor, Emory University. Atlanta Site Director, Birmingham Atlanta GRECC, Atlanta VAHCS Continence Clinic Director. Elaine D. Markland, DOMSC. Elaine D. Markland, DOMSC Professor, University of Alabama, Birmingham, UAB. Director, Birmingham Atlanta GRECC. Birmingham VAHCS Continence Clinic Director. Slide 25. Contextual setting. The VI network is the largest integrated health system. Access, advocacy, outcomes, and excellence. Increasing numbers of women veterans using the VI. 30% of women in the U.S. suffer from UI. Graphic illustration of a map of the United States showing the dense network of veterans' healthcare. Slide 26. Intervention. Clinical practice interventions. SharePoint website. Education. Screening for UI. Data dashboard. Continence clinic referrals. Slide 27. Intervention, patient intervention. Infographic showing the flow from the mobile health application to the My Healthy Bladder program, which flows to behavioral treatments including behavioral strategies, lifestyle modifications, bladder training, bladder health education, monitor adherence and barriers, pelvic floor muscle training and exercise. Slide 28. Implementation approach. Key strategies pursued as part of the implementation process included the following. Recruitment. Provider. Education resources. Identify site champion. Clinic engagement. Program feedback. Clinic size, large, more than 500 women veterans. Medium, 100 to 499 women veterans. Small, 50 to 100 women veterans. Slide 29. Implementation process, tools created. Screenshots of several tools created to support the implementation process, including the Pursuit Dashboard Provider Manual, web content, and mobile application. Slide 30. Implementation process, roadblocks, patient data dashboard. Identified real-time patient information from the EMR patient panel organized by women with the most recent scheduled appointments. Each patient had their risk factors highlighted. Screenshot of the patient data dashboard with magnifying glass, showing the details of the percent of panel DX with LUTS. Slide 31. Wins and woes. Challenges were mainly due to schedules and provider engagement. Facilitated direct patient recruitment with more than 37,000 letters sent. Enrolled 3,200 women veterans in MHB. Graph of patient enrollment into MHB provided with key data described by presenter. Slide 32. Uptake considerations must have leadership support at the facility level. Nursing staff is the key to getting buy-in at the clinic level. Collect clinic information. Start by educating clinic staff. Slide 34. Preliminary data shows a 2 to 6% increase in LUTS diagnosis across the clinics after 6 months. Varies across states and clinics, highest among clinics focused only on women veterans. Increases in diagnosis seen with increased numbers of women veterans. Timing of the feedback with the clinic champions is important. Month virtual meeting often leads to new engagement or re-engagement in the program. Providers and staff are receptive to having a treatment for UIY, especially if it is veteran-centric and endorsed by the VI. Women veterans are telling their providers and other veterans about our program. Connect and build relationships with key players in the clinic. Only giving feedback on data may not be enough for success. Slide 35. Clinical staff ranged from not being engaged to being extremely committed and passionate. Having a site champion may be a key factor. Women veterans loved MHB content and had symptom improvement, receptive to being screened for UI and primary care. Thank you for your pursuit in smarter UI care for women veterans. Slide 39. Available resources. Table with 3 columns: product, description, audience. 1. MUI perspectives from the field. Written interviews with 3 of the MUI grantees, reflecting on implementation of their initiatives in primary care. Healthcare administrators, quality improvement staff, practice facilitators, PCPs, practices treating UI researchers. 2. MUI webinars. Recorded webinars highlighting the 5 MUI grantee projects. Researchers, practice facilitators, PCPs, and practices treating UI. 3. Patient resource library. Webpage containing resources to help patients understand and manage their UI. Women experiencing UI.MUI tools and resources library repository of tools and grantee developed resources on engagement, recruitment, and retention. Practice facilitators, PCPs, and practices treating UI. Slide 40. Perspectives from the field. Interview with the WI Intuit project team. Project overview. The Wisconsin Improving Nonsurgical Treatment of Urinary Incontinence Among Women in Primary Care, WI Intuit team from the University of Wisconsin-Madison, is comparing streamlined practice facilitation, SPF, and SPF in combination with partnership building. WI Intuit is working across a wide variety of primary care practices across the state. For more information on WI Intuit, read their project's executive summary, PDF 203 KB. Heidi Brown, MD, MAS, FACOG, clinician scientist, Kaiser Permanente Southern California in place for the WI Intuit project, responded to interview questions on behalf of our team. At a 30,000-foot view, what is most notable about your team's approach to urinary incontinence, UI screening and treatment implementation within primary care? What strategies were central to your project? Slide 41. Screenshot of the MUI Tools and Resources Library search results page. Slide 42. Implementation tools. Resources available at https://www.ahrq.gov/evidencenow/projects/urinary/resources.html. Empower team. Interactive UI care pathway tool. Sustainability menu. Pursue team. Patient recruitment flyer. Clinician pocket guide. IT2 team. Clinician education module. Optima team. Clinical decision support tools. UI pocket guide. Academic detailing videos. WI Intuit team. UI practice launch toolkit.